Hello, everybody. I'd like to thank the Fifth Congress Arab Thyroid Association Organizing Committee for the kind invitation. And as usual, as a pediatric endocrinologist, I'm going to tackle a pediatric topic, which is congenital hypothyroidism. And this is when time matters. And let me start by the story of these two gentlemen driving this airplane. And when you follow the rules, you enjoy the trip. But unfortunately, when you do not follow the rules, you can crash. And this applies to congenital hypothyroidism. And let me take you to the story of this 2-year-old girl who presented with a midline swelling at the base of the tongue, gradually increasing in size with mild dysphagia, fatigue, weight gain, and the neonatal screening results were normal. And then she presented at the age of 2 years with a high TSH, low T4, and antibodies negative. The thyroid gland was not palpable in its normal site in the neck. The neck ultrasound showed normally located hypoplastic thyroid, and the thyroid scan showed 2 foci of intense uptake at the base of the tongue and the submental region, while the uptake in the normal thyroid bed was very weak. So the diagnosis was congenital hypothyroidism with dual ectopic thyroid and hypoplastic utopic thyroid. So the suggested management here was surgical removal of the sublingual thyroid because there are pressure symptoms, and starting thyroxine therapy. Now, which way shall we go when we look at congenital hypothyroidism? Of course, primary is the most common. This is 90%, and secondary is very uncommon. And neonatal screening is very important to detect primary congenital hypothyroidism to avoid this cretin appearance. Unfortunately, the screening program misses the cases of secondary congenital hypothyroidism. So the first question that we need to answer, is it primary or secondary? The second question, which is very important to the parents, is it transient or permanent? And we need to reassess the thyroid axis at the age of 3 years. And finally, we put the treatment plan to answer the question, is it a lifelong therapy or not? As you see here, permanent congenital hypothyroidism is either due to development thyroid dysgenesis or function abnormality, which is dyshormonogenesis, or rarely defect in hypothalamo-pituitary disorders. And the incidence of congenital hypothyroidism is a rising incidence. And there are a lot of genes associated with congenital hypothyroidism, whether dysgenesis, dyshormonogenesis, or central hypothyroidism. And here you can see what we already knew about the genes involved in thyroid ectopy, hypoplasia, or aplasia. But there is a lot of genes being discovered. And in the article on the left side, you can see newly discovered genes in the genetics of congenital hypothyroidism published in 2022. And in the box on the right side, you can see the genes involved in thyroid dysgenesis. Another question raised, could congenital hypothyroidism be associated with other congenital anomalies or system affection? And in this table, you can see the incidence of associated anomalies in different countries. In Egypt, my country, you can see a very high incidence, 70% of cases being associated with other anomalies in addition to thyroid affection. And this gives us a message to screen for congenital anomalies in infants with congenital hypo. Another story is a 1-month-old infant born to first cousin parents, full term, normal birth weight and length and skull circumference. The boy had choanal atresia on the right side, cleft palate, and unfortunately skipped neonatal screening program for congenital hypothyroidism. At the age of 1 month, the mother noted excess sleepiness and poor feeding, and for this reason, thyroid functions were done. You can see a very high TSH with low T3 and T4. The ultrasound revealed athyrosis, and the scan confirmed no tracer uptake at the site of thyroid. So the next step was genetic testing. And here you can see FOXE missense mutation being detected. And this is a novel FOXE mutation that we published in Thyroid Journal. And this is the first gain of function FOXE mutation. What is already known on this syndrome and is that it is an autosomal recessive loss of function FOXE gene mutation causing thyroid dysgenesis, in addition to cleft palate, spiky hair, choanal and bifid epiglottis. This is Bamforth-Lazarus syndrome. This is what's already known, but in our case, this was the reverse. We found gain of function mutation. And the message here is that the genetics of congenital hypothyroidism differs between Arabs and Europeans. Another story is a 10-year-old girl with midline swelling of the neck noted at the age of 2 years, cystic, gradually increasing in size, moving on swallowing and protrusion of the neck. It's asymptomatic with no pain, discharge, and normal neonatal screening results were noted. And when we did the thyroid function, the TSH was high with a normal T3, T4, and negative antibodies. So the classic diagnosis was subclinical hypothyroidism. And the ultrasound revealed a thyroglossal cyst, while the thyroid gland was not visualized in its fossa in the neck. The thyroid scan revealed ectopic thyroid anterior to the hyoid within thyroglossal cyst and absent uptake in the normal thyroid bed. And this was confirmed by CT scan. In fact, there is a risk of carcinoma in such cases, approximately 1%, when the thyroglossal cyst contains ectopic thyroid tissue. So the diagnosis here was late-onset congenital hypothyroidism, very late onset to be honest, ectopic thyroid inside the thyroglossal cyst and infrahyoid. And the suggested management was surgical excision of the thyroglossal cyst and tract because it's liable to recurrent inflammation and 1% carcinogenic. Plus, we started thyroxine replacement therapy because the child had hypothyroidism. Now, moving on to thyroid hormone synthesis. And this is a really complex multi-step process with a lot of genes being involved in the thyroid hormone synthesis. Again, there is a very long novel list of genes being involved in mutations associated with dishormonogenesis. Now, let me take you to the story of this 8-day-old neonate who had uneventful birth history, asymptomatic, and the TSH on neonatal screening was not very high, but a little bit high, 14, with a normal T4 and thyroid ultrasound. And the question here was to treat or to wait. In such a case, when the TSH did not exceed 20, we wait in the presence of a normal T4 and a normal ultrasound. And then the baby came 2 weeks later when we repeated the TSH, it became up high, it jumped to 22. But the T4 is still normal, and again, the ultrasound is normal. So the question here to treat or to wait. Here we have to treat because TSH exceeded 20. So what's the critical cutoff TSH level to treat in such case? And this is when time matters. Let me share with you the JCEM guidelines published by European Society of Pediatric Endocrinology on how to deal with infants with congenital hypothyroidism. Now, based on filter paper TSH with neonatal screening, if the T4 is above If the TSH, is above 40, you have to start and do imaging. Less than 40, take a venous blood sample. If the T4 is below the normal or TSH above 20, you have to treat, even if the T4 is normal. And the thyroid scan is mandatory if you cannot visualize the thyroid gland by ultrasound to exclude ectopia. Now, this is the gray zone. When the TSH is 6 to 20, retest after 2 weeks and do imaging. Ultrasound or scan if you cannot see the thyroid gland by ultrasound. And these are the guidelines published by American Academy of Pediatrics, again applying the same cutoff values. Above 40, you have to treat. Above 20, repeat the sample and treat. T4 being low, you have to treat. And the gray zone from 6 to 20, repeat the thyroid functions after 2 weeks. So decision in this gray zone is controversial. But in infants with mild subclinical hypothyroidism, more than 70% resolve spontaneously, which is a very good percent. And the indications of starting treatment in infants with subclinical hypothyroidism, if the TSH persists above 10, more than 4 weeks of age, symptoms suggestive of hypothyroidism, or if you have a clear proved dysgenesis like ectopia or aplasia. And there are concerns about neurodevelopment and growth. So if you're not sure, you have to treat. And these are latest guidelines published by ENDO-ERN 2020 and 2022. And they use the same cutoffs published by SP guidelines, and this was published in thyroid journals. You can see the T4 dosing in the table above. Again, they clearly stated that you have to start T4 as soon as possible, not later than 2 weeks. And again, if the TSH is above 20, you have to treat. What about monitoring of the treatment? When? You either withdraw the blood sample before giving the dose or 4 hours after the last T4 dose. Our target is to have a TSH in the age-specific reference interval and the T4 being in the high normal for brain development. Now, going to the less common type of congenital hypothyroidism, this is the central hypothyroidism. Again, you can see the lately published list of novel genes for central hypothyroidism, and it's either isolated central hypothyroidism or part of panhypopituitarism, or it could be a part of syndrome. And I would invite you to visit this nice paper published in Pediatric Investigation 2022 to have a look at the genes. Now, let me share with you the story of this 1-month-old male baby born to non-consanguineous parents, full term with a normal birth weight, length, and skull circumference. The screening for congenital hypothyroidism came normal because the TSH is not elevated. But the mother noted progressive feeding difficulties, a little bit of hypotonia, somnolence, jaundice, and being a bit sleepy. And based on this, the pediatrician ordered T4, T3, and TSH. You can see here low free T4 and T3 and low TSH. And the rest of pituitary hormones were normal, MRI brain was normal, and the thyroid ultrasound came normal. So this is a case of isolated central hypothyroidism. When referred to us, this triggered us to do genetic testing, and we found TSH beta gene homozygous single nucleotide deletion, which was the cause of this central hypothyroidism, and the baby was controlled on 25 micrograms a day of thyroxine. And this is what usually happens with central hypothyroidism. They need smaller doses of thyroxine compared to the primary. Now, this is a nice article, again, the 2018 European Thyroid Association Guidelines for Diagnosis and Management of Central Hypothyroidism. And in the table on the right side, you can see diagnostic findings in such cases. Evidence of central hypothyroidism in first-degree relatives, delayed growth, hearing affection in some cases, macroorchidism, insufficiency of other pituitary hormone in some cases, low or normal T4, low or normal TSH. And this raises the question, do we need to add free T4 to screen for congenital hypothyroidism? because, as you know, such cases are missed in the neonatal screening because it detects the high and not the low or the normal TSH. And the answer here was, when financial resources are available, it is recommended to add measuring free T4 to TSH in order to detect cases of central hypothyroidism. Again, if you have low T4, low or normal TSH, think of central hypothyroidism. Now, the question again, re-evaluation of thyroid axis in babies with congenital hypothyroidism, speaking about the whole category. And we have 3 questions to answer: who, how, and when. Who? We re-evaluate the thyroid axis in those with no definitive diagnosis of permanent congenital hypo made in the first weeks or months of life, especially in children who have the gland in situ and isolated, presumed central hypothyroidism. How? You either stop the treatment gradually over 4 to 6 weeks, or you just stop it. And I follow the school of just stopping it and reassessing. And then you repeat after 2 to 4 weeks, measure T4 and TSH. And when? At the age of 3 years, to ensure brain development is completed. Another question: when is re-evaluation not indicated? You just continue the treatment. If you have a clear diagnosis of thyroid dysgenesis, if you have dysharmonogenesis confirmed by genetic testing, or if you have progressive rise in the TSH and you are increasing the dose of T4. In such a case, you just continue treatment and you don't have to re-evaluate. And finally, this important item, I think it needs a lecture by itself. Transition from pediatric to adult care. It is challenging because there is a risk of poor compliance and inadequate follow-up, which increases the morbidity, educational, and social outcome. So I think the pediatric and adult endocrinologist should work hand in hand to cover this gap. It needs special attention. And my final conclusions here are: primary congenital hypothyroidism is easy to detect by neonatal screening, but could present later in childhood or with subclinical hypothyroidism. Immediate start of correctly dosed T4 treatment at the proper time and follow-up are recommended. And as I told you, if you're not sure, start treatment. Timely assessment of the need to continue treatment and attention to neurodevelopmental function are crucial. And this is really important in pediatrics. It's not like adult. Harmonization of diagnosis, treatment, and follow-up optimizes the patient outcome. Despite 50 years of neonatal screening for congenital hypothyroidism, some important questions remain, like genetic etiology of congenital hypothyroidism, assumed harm of subclinical hypothyroidism, and the cause instead of incidence of congenital hypothyroidism with the gland in situ. TSH neonatal screening misses the diagnosis of central hypothyroidism, and this raises the question of whether to add free T4 to the screening or not. Genetics of congenital hypothyroidism differs between Arab countries and Europe, like the cases and mutations I showed you. Transition from pediatric to adult care is challenging, and again, we pediatric endocrinologists and you adult endocrinologists need to work hand in hand on this. And let me tell you that children with congenital hypothyroidism who are treated early are clever and charming. As you see their photos with me, they are really lovely, smart, active, intelligent kids who are super in all academic and sports and other activities. So finally, let me tell you that the bad news is that time flies, but the good news is that you are the pilot. We and you are the pilots who drive the plane. Remember the 2 gentlemen who were driving the plane at the beginning of my talk? And if they drive carefully, they enjoy the trip. But if they drive without care, they can crash. And this is what applies to congenital hypothyroidism, especially in pediatrics. And this is when time matters. Thank you very much for your attention.